Hi, my name is Becca Mullen, and I'm an assistant professor in the Department of Family Medicine. And I am so excited to be here to talk with you about dementia. And specifically, this is week 1 in your mentation unit. We have a lot of content to cover, so let's just dive right on in. So, what are our learning objectives today in our discussion about normal cognitive aging versus dementia? We are going to discuss the dementia definition and stages, specifically defining dementia versus Alzheimer's disease and normal cognitive aging. We will also describe the stages of dementia in that conversation. We will also discuss dementia symptoms and specifically tease out the differences between normal cognitive aging and dementia, and describing the signs and symptoms of dementia, including behavioral and psychological symptoms. And finally, we will go over dementia detection and diagnosis, including describing cognitive assessment strategies and understanding the current steps of dementia diagnosis. So I know this seems like a lot of content. It is, but I really hope that I presented it in such a way that it's applicable to anyone who's working with older adult populations, so that you can have some really key practical takeaways. Here's just another way to think about our presentation today. This is a roadmap of the presentation. So first, we're going to go over definitions. We'll define dementia and again compare it to Alzheimer's disease and compare that to normal cognitive aging. We'll go over the stages of dementia, and then we're going to review the symptoms of dementia and again compare that to what typical aging may look like. And then we're going to end on early detection and diagnosis, and I will make a brief note on treatment at the very end. Okay, so let's get to the meat. What is dementia? Dementia is really this umbrella term for loss of memory and other thinking abilities that is severe enough to interfere with daily life. So I want you to notice that there are two parts to that sentence. The first is the loss of memory and other thinking abilities, and then the second is severe enough to interfere with daily life. And those two parts are both key to the definition and diagnosis of dementia. And again, interfering with daily life, this impacts someone's function and independence. And that's really key in dementia, in teasing it apart from what might be typical aging, or even from another diagnosis that we'll talk about, which is in between typical aging and dementia, and is called mild cognitive impairment. Dementia is gradual in onset. It is chronic, so once you have this diagnosis, it doesn't go away, and it is progressive, so it becomes worse over time. And really importantly, to diagnose dementia, really as a part of this diagnosis, these changes cannot be explained by delirium or depression. And I know you have a whole nother discussion and presentation on these two things in a couple of weeks. So how great and important is that? So again, this dementia is a decline in cognition that involves one or more cognitive domains. And so you can see here that memory is actually just one potential domain that someone may be having issues in. So although we typically think of memory as the aspect of someone's decline in dementia, actually cognition is much broader than just memory. Now, memory is the most common aspect of cognition to be impacted when we're thinking of dementia, but I just want to highlight there are a lot of other potential cognitive abilities that can be impacted in dementia or mild cognitive impairment for that matter. So that would include language, things like fluency or even object naming, also executive function, things like planning and decision making, complex attention, which may include sustained attention or selective attention, or even processing speed. Perceptual motor entails things like coordination or visual perception, and even social cognition, which is your ability to recognize emotion or respond to social cues or even have insight. And I want to importantly highlight that dementia is not a normal part of aging. So this may go without saying for some, but this is actually contrary to many people's common belief that they just assume that severe declines in memory or cognition are just a part of life. That is not the case. Dementia is abnormal. It is an official diagnosis and a condition that is worth getting evaluated and diagnosed. And also, I want to note on the opposite end of that spectrum, there is a stigma, particularly in certain cultures or in certain circles, on again on the opposite end of that spectrum, that dementia is the same as being crazy or being mentally ill. And so that all goes without saying that it's worth having more conversations about dementia and about memory changes. And then we can break down this taboo about, what is normal memory decline with aging versus what is atypical and what might we not expect to see as we age, and then is really worth telling people about and getting evaluated. All right, so let's tease apart dementia versus Alzheimer's disease, because these are sometimes conflated as being the same, and they are definitely not the same, but it's confusing. So what is Alzheimer's disease? Alzheimer's disease is the most common cause of dementia, and it accounts for 60 to 80% of cases of dementia. So you can see here this great picture from the Alzheimer's Association of an umbrella. This is our umbrella of dementia, this umbrella of loss of memory, other thinking, with this list of types of dementia and Alzheimer's being at the top. So again, Alzheimer's is just the most common cause of dementia. But just to make things more confusing for us, you can have Alzheimer's disease and not have dementia. And again, this comes into play with this intermediary diagnosis that we'll talk more about called mild cognitive impairment, or MCI. And we will dive deeper into that in a few more slides. You can see, though, that there are other different causes of dementia, including vascular dementia, Lewy body dementia, etc., which can all be bundled into a term of Alzheimer's disease and related dementia, or ADRD. And Alzheimer's in particular is very prevalent. 1 in 9 of those 65 and older has Alzheimer's dementia. And this just continues to increase with age. By the time we get to 85 years, over 33% of adults have Alzheimer's dementia. So staggeringly high. Now, this is not a talk about Alzheimer's dementia or Alzheimer's disease specifically, meaning not a talk about the cause of Alzheimer's disease, but I need to make a special shout out about Alzheimer's biomarkers because I will be referencing them multiple times throughout this presentation. So Alzheimer's disease, just in brief, is caused by an accumulation of a couple of proteins, beta amyloid and tau, in the brain. And this is accompanied by a whole variety of different processes such as neuron death, brain tissue damage, brain inflammation, and even brain atrophy. And again, this will just be important later when we talk about the diagnosis and assessment of dementia, and then again later when we talk about treatment. Okay, so let's take a second to define mild cognitive impairment, or MCI, that I keep referring to. This is an early stage of memory loss or other cognitive ability, such as language or visuospatial perception, or one of the other cognitive aspects that we referred to on the earlier slide. But here, in comparison to dementia, individuals maintain the ability to independently perform most activities of daily living. So you can really see that severity difference. So this is considered an intermediate state between normal cognition and dementia. So there are objective cognitive impairments, but no decline in overall level of function. And here we again see that this is really prevalent. 12 to 18% of those above the age of 60 have MCI. You also see that memory or cognitive changes here are serious enough that family and friends can notice it. But again, it's just that the person has maintained their independence and function. So in most cases, MCI will progress to dementia. And this is kind of in this continuum in stages of cognitive impairment or stages of dementia. So 10 to 15% of individuals with MCI will develop dementia each year. And about 1/3 of individuals with mild cognitive impairment due to Alzheimer's disease will develop dementia within 5 years. However, it is possible for those with MCI to actually revert back to normal cognition. Now, how might that be? Well, we think that this likely represents when someone is diagnosed with MCI and they have a reversible condition, such as depression, a medication complication, or maybe an acute illness. So this really highlights why it is so important to do a really thorough evaluation of someone's medical history and what might be potentially be contributing to someone's cognitive impairment when you are pursuing a diagnosis of dementia, because MCI actually can revert back to normal. Also, a diagnosis of MCI may remain stable and never become more severe. And here we illustrate the stages of cognitive impairment or dementia on a continuum. But as I just illustrated, you don't necessarily progress through this continuum at all. But I do want to illustrate here that for many people, it is this continuum, and particularly as we discussed at the beginning slide, once you get to that diagnosis of dementia, it really is considered to be a progressive chronic disease. And we differentiate between these stages, particularly once you get to the diagnosis of MCI, we differentiate between these stages by their symptoms, by worsening symptoms that increasingly interfere with everyday activities. And I want to state that although these arrows and boxes are all of equal sizes, these are not necessarily of equal duration. And also, as mentioned, someone does not necessarily move through all of these stages. So when we're specifically thinking about Alzheimer's and Alzheimer's dementia, it's important to note that changes in the brain related to Alzheimer's disease actually begin 20 years or more before memory loss and other symptoms develop, meaning you don't yet have the classic symptoms of Alzheimer's disease yet, but you may start to have the biological changes in the brain happening that will lead to Alzheimer's disease in the future. So then this really begs the question, is that really a normal cognitive aging in that first box, or is there really a time that you're actually preclinical Alzheimer's disease? Or some people would substitute that with asymptomatic. So in this phase, individuals may have measurable brain changes that indicate the earliest signs of Alzheimer's disease, such as abnormally increased beta amyloid or tau on PET scans, but they've not yet developed symptoms such as memory loss or difficulty thinking. So this is really important because this indicates that there is a substantial window of time to intervene on the progression of Alzheimer's disease as it progresses through before to dementia. And so understanding this and understanding that there are modifiable risk factors for Alzheimer's dementia and that you can strategically reduce those risk factors can significantly impact someone's future and someone's future's risk for Alzheimer's. So this is technically outside of the scope of this talk. It was not about the risk of Alzheimer's disease, but I can't help but divert just for a second to talk about this because this is so wildly important, I think, for all of us taking care of older adults, for all of us with older adults in our lives, but also all of us, with anyone who may be worried about our own risk of dementia in our future, or as I'll describe this figure in just a second, as you'll learn, we can actually be doing things in our own lives right now. Because as we're thinking about reducing our risk for dementia in the future, as I just talked about with the changes in our brain beginning 20 or more years before symptoms develop, wow, that means we need to be beginning today, right? And so this is a figure from the 2024 Lancet Commission article that detailed 14 modifiable risk factors for dementia. And this figure illustrates those 14 modifiable risk factors, and importantly, even provides the amount, the percentage that you can reduce the risk of dementia if this risk factor was eliminated. And you can see here in that quote that close to 50% of cases of dementia worldwide can be prevented or delayed by improving 14 modifiable risk factors. Meaning if you go through and you add up all of those little bubbles, add up all of those percentages, it will add up to close to 50%. It adds up just to over 45%. So over 45% of dementia is potentially modifiable. So this is big news, people. So I just want to briefly highlight a few things, particularly in the midlife and late life, as we're going to go to this yellow section here. You can see that many of these risk factors are within the healthcare setting. So, and these are listed here in order of importance. So in order of the highest impact on future risk of dementia. So hearing loss, wow, if you eliminate hearing loss, 7% reduction in future dementia risk, that's major. High cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension. You could see that many of these are medical comorbidities that are already being addressed in the healthcare setting. But we can refocus them as not only heart health factors and cardiovascular risk factors, but also their brain health factors. And if we can do things like address your high LDL cholesterol, did you know that you're also significantly reducing your risk for future dementia? So it's just a reframing, but it's a really important reframing. And I also wanted to bring this to everyone's attention because many of these risk factors are also outside of the one-to-one clinical healthcare setting, or they can be. So again, hearing loss. I mean, that's everyone. That's anyone who's interacting with an older adult at any time. If you notice someone is having hearing impairment and they don't have hearing aids, just by encouraging them to get that addressed, you can make a huge difference on their future risk of dementia. And if you go down to the blue bubble, the risk factors in late life, things like social isolation and loneliness, you can, if you help someone address their social isolation and loneliness, you can have up to a 5% reduced risk of dementia. So again, this is just really exciting stuff, and I think just really can impact us all, but also has major implications to working with older adults. Okay, so now let's switch back gears to what this talk is really supposed to be oriented about, which is the signs and symptoms of dementia and how that may differ from more typical cognitive aging symptoms. And I'm going to start us off with the 10 warning signs of, this says ADRD, Alzheimer's disease and related dementias, and that's because that's the language of the Alzheimer's Association, who put together these 10 warning signs for us. And we're going to start here because I think these are really digestible. And I even use these in clinical encounters with my patients because patients come in so often saying, wow, I'm having memory concerns. I don't know if this is normal or if it's abnormal. I forget my keys everywhere. I forget my phone everywhere. So I even have printouts of these 10 warning signs that I use to help me in conversation with my patients. And so if we just go through these together, you can see that it starts with memory loss that interferes with daily life. So this again, I'm going to emphasize interferes with daily life. It's not memory loss that is just kind of one-off and you can go about your life and it doesn't really impact you significantly. This may be things like forgetting a really important date or forgetting an important event that happened to you in the past. Or maybe it's asking the same question over and over and over. Or maybe it's increasingly needing to rely on others to remember things. Next, we have challenges with planning and problem solving. This may include difficulties developing and following a plan, such as keeping track of your monthly bills. Next, we have difficulties with familiar tasks. Maybe it's following a familiar recipe or trouble driving to a familiar location that you always knew how to get to. Next, we have confusion with time or place. And in particular, this is not just a one-off of temporarily getting confused about the day of the week or the date, which happens to me all the time. This is more like consistently having trouble keeping track of dates, or maybe the season, or maybe even as severe as forgetting where you are. Sometimes people with dementia experience vision changes that can lead to difficulty with balance or trouble reading, and this can also lead to issues with judging distance and even can cause issues with driving. You can also see new problems with words, and in particular, people with dementia may have trouble following or even joining in on a conversation. They may repeat themselves over and over, or they may have difficulty with word finding or even switching up words in sentences. People with dementia may misplace things, and importantly, they lose the ability to retrace their steps to try to find where they misplace things. Or they may even put things in really unusual places that you wouldn't think to look. They may have decreased judgment, such as when dealing with money, or maybe they may pay less attention to their grooming or personal hygiene. You may see that they withdraw from work or social activities, such as participate less in their hobbies or other social engagements. And again, this may in part be due to just difficulty in the ability to hold and follow a conversation. And finally, we do see sometimes that people with dementia have changes in mood or personality, which we'll talk about a bit more in subsequent slides. So now let's put some of those warning signs into context of the continuum of dementia. So by stage of cognitive impairment. So as I already mentioned, we have this continuum here of cognitive impairment, starting with mild cognitive impairment and then moving through mild dementia, moderate dementia, and severe dementia. And you differentiate these by worsening symptoms that increasingly interfere with everyday activities. So let's dive into what some of these different symptoms may be, depending on where you may fall on this continuum. Starting with normal cognitive aging. So I just want to first point out, learning new information is very common with aging. That's almost universal. But issues with memory is not necessarily universal. So what are some typical aging symptoms that you may see in relation to memory decline? You may see things like forgetting names or appointments, but then you might remember them later. Making occasional errors when doing bills or finance, occasionally needing help with technology, difficulty with multitasking, sometimes forgetting which word to use and recognizing that this is hard for you, misplacing things but having the ability to retrace your steps to find them, forgetting which day it is and remembering it later. So you can already see that there's a difference here from some of the warning signs that I just mentioned with the ability to, remember later things that you've forgotten, or the ability to retrace your steps when you've misplaced things, which are really common with aging. Now, when we move into atypical cognitive impairment, with the first stage being mild cognitive impairment, some of the first things that we start to see decline include short-term memory issues. You can see difficulty keeping track of your wallet or purse and really consistently not being able to find where you put it. Maybe difficulty paying bills, problems with planning and preparing meals, problems with remembering appointments, or maybe difficulty traveling out of the neighborhood. So these are just broad examples, but you can see that in comparison to normal cognitive aging, they're on a bigger scale and they're more consistent issues instead of just being one-off little examples that aren't interfering with your day-to-day life. In comparison, mild cognitive impairment become bigger issues that again, it may not impede with your ability to be independent or your ability to function, but start to become more atypical. Now here, there's a lot on this slide. I know it's a really busy slide, but here are some symptoms that fall over the scale of dementia, mild versus moderate versus severe. And I do want to say that the rate at which the disease progresses over time may vary, and this outline just provides an overall idea of how these abilities may change over time and is truly just a general guide. It can really be hard to specifically place someone neatly in a bucket at any given time, and so again, this is just supposed to be a general guide or a general outline. But starting with mild dementia, or if you're working with someone with Alzheimer's disease, this may be called early stage Alzheimer's. Someone may, in this bucket, again, importantly, someone may still function independently and symptoms may mostly be noticeable to close family or friends, but a clinician would be able to diagnose them using appropriate assessment tools. And so these symptoms may include difficulty finding the right word or name, forgetting material that you just read, difficulty performing tasks in social or work settings, losing or misplacing a valuable object and not being able to retrace your steps, and having increasing trouble with planning or organizing. And you can see that these symptoms overlap quite a bit in some ways with the mild cognitive impairment symptoms. And that's why we don't diagnose MCI or dementia based on symptoms alone, because it's absolutely true that when you have MCI and when you move into mild dementia, a lot of those symptoms may continue to overlap. Now, moving into the moderate dementia, or if you have Alzheimer's, this may be called middle stage Alzheimer's. For many people, this can be the longest stage and actually may last many, many years. And typically during this stage, symptoms become more pronounced. And it's during this stage that someone may end up requiring a greater and greater level of assistance and care. But individuals can often still participate in their daily activities with some assistance. So these symptoms may include increasingly forgetful of events, particularly maybe even important events, feeling moody or withdrawn, confusion about the day or the location, inability to recall personal information, including things like your own address or maybe even historical information about yourself like your alma mater, difficulty with bowel and bladder control, change in sleep patterns such as sleep during the day and increased restlessness at night. This is where you may increasingly see people wander and get lost. You may see personality and behavior changes such as increased suspiciousness, delusion, or even compulsiveness. And you may see repetitive behaviors like hand wringing or tissue shredding. So it's in this moderate dementia stage where you're often starting to first see behavior, significant, I should say, behavior and personality changes and significant symptomatic changes in the way of bowel, bladder control and wandering. Now, that's most true for Alzheimer's dementia and not always true for other causes of dementia. Now, moving into severe dementia or late stage Alzheimer's, if you're talking about Alzheimer's dementia. And this is in the final stages where dementia symptoms are obviously the most severe. And it's in these stages where individuals often lose the ability to respond to their environment completely. They may not be able to carry on a conversation. They may not even be able to control their own movement. Communication can become very severe, maybe even impossible, and significant personality changes may occur. So you can see here in these list of symptoms that people can just completely lose awareness of their surroundings. And it's really in this stage where people often first require just around the clock assistance with daily personal care. Although for some people that may start in the more moderate dementia as well. And again, this is where you see those severe changes in physical abilities, including even walking, sitting, and eventually even swallowing. Okay, so moving on past symptoms, now let's discuss early detection and diagnosis. Now, first things first, elephant in the room. Why might we even go down this path? Why might we even want to detect dementia and diagnose dementia, particularly when it's very commonly known that we don't have a cure. We don't have a cure for Alzheimer's and we don't have a cure for dementia. Well, probably most importantly, because patients want to know. And as you can see in this figure, the stage at which US adults would want to know if they have Alzheimer's disease. Most adults would want to know at the earliest stage, at mild cognitive impairment, before they even have the official diagnosis of Alzheimer's dementia. And it's definitely not that they never want to know. As you can see, only 5% never want to know. And so that's probably really all that we could just stop there, right? Like if patients want to know, that's the end game. But if you need even more ammo, then also know that it may not be Alzheimer's or dementia. So if someone is presenting with memory concerns or cognitive impairment, there are a significant number of conditions that are considered dementia mimics that actually are completely treatable and reversible. So it's really important to go down an evaluation pathway to make sure you're not missing something that can be treated. Also, having a diagnosis can help patients remain independent longer. It's known to help with care planning, future decision making, provides patients and family members with a lot of considerations for potential treatments, increased quality of life, opens up the doors for conversations to participate in clinical trials, which they wouldn't have had otherwise if they didn't have the diagnosis, and is known to prevent hospitalizations among persons with dementia. So who might you have this conversation about in regards to early detection and diagnosis? Who might you start down this pathway? Well, there are a variety of reasons why you might want to consider doing an evaluation for dementia or Alzheimer's disease. So for example, if someone has experienced a functional decline or a new personality change, or maybe if an older adult is being evaluated for depression or loneliness or social isolation, then you should also incorporate some questions about new memory issues. Or if there's been any new deterioration of another chronic illness without clear explanation, or if there's a new fall or any new balance concerns. We've also already discussed the warning signs of Alzheimer's disease and related dementias as published by the Alzheimer's Association, again illustrated here. So if any person presents with any of these warning signs, these are all reasons to kind of go down a detection and diagnosis pathway for that person. So how might you do this? And what do I mean by early detection versus diagnosis? So early detection is really more about screening for cognitive impairment. And you might even do this even if someone doesn't bring up memory issues as a concern. So you might think about asking about memory issues in older adults when you see them, for example, at like an annual exam. For example, at a Medicare annual visit, you might want to consistently think about asking about memory concerns. You can just ask them in your interview or in casual conversation. You could also be more formal about it and conduct a brief cognitive screen. And there are a variety of different cognitive assessment tools that I will go over in a subsequent slide. And then if this comes up to be abnormal, whether the person, endorses abnormality in the discussion, or if the cognitive assessment tools have an abnormal test, then you could encourage or schedule outside follow-up for a more full and formal evaluation. And depending on the circumstances here, maybe that's, just coming back to your primary care setting or encouraging someone to go see their primary care provider, or maybe it's scheduling someone or encouraging them to go to subspecialty follow-up as needed, such as neurology, neuropsychology, geriatric psychiatry. And you can also point people to lots of different helpful resources online, such as the Alzheimer's Association, etc. So now let's talk about how we officially diagnose dementia. And this is actually an ever-changing field. How lucky are we? But currently in practice, the diagnosis of dementia or even Alzheimer's dementia is typically done using the DSM-5 criteria. And that uses a combination of patient symptoms, neuroimaging, and occasionally uses those biomarkers that I referred to that are associated with Alzheimer's related changes in the body. So specifically the beta amyloid and tau protein. And these biomarkers in this circumstance are helpful in the diagnosis of MCI or dementia, and or can be used if you're trying to differentiate, is this MCI or dementia due to Alzheimer's or due to another cause? But these 4 steps will be outlined in more detail in subsequent slides. But I just want to highlight the first step. Wow, is it important? It's one of the most important steps actually highlighted here, and it includes a thorough medication review and a functional assessment of the individual's activities. You'll also do cognitive testing, specifically with a variety of different cognitive tools that again I'll outline in more detail. And then you'll want to exclude treatable and reversible causes. So again, I've alluded to this multiple times, but there are dementia mimics. And there'll be a subsequent slide that will talk about some of these in more detail and how you might exclude them. And then this process also includes typically brain imaging, most commonly brain MRI over a non-contrast CT. So let's close the loop back to our first slides about the definition of dementia and how these steps might get us there to diagnose dementia. So let's remind ourselves, dementia is a cognitive deficit that interferes with independence in everyday activities and cannot be explained by delirium or depression or a mental health disorder. So you could imagine these first 2 steps, the history, the medication review, functional assessment, and the cognitive assessment, get us to that first piece of the dementia definition and diagnosis. Having a cognitive deficit that interferes with independence in everyday activities. And then you need to know that it cannot be explained by something else, which are the second 2 steps, excluding treatable reversible causes and the brain imaging. But before we move on, I do have a major caveat about the diagnosis of Alzheimer's dementia specifically. And actually, this isn't just applicable to dementia, this is also applicable to Alzheimer's mild cognitive impairment, or in other words, mild cognitive impairment due to likely Alzheimer's disease. So there is a big movement happening right now, just started in the summer of 2024, if you will, after a publication in the Journal of Nature, where basically there is a movement to diagnose Alzheimer's disease based on the presence of biomarkers alone, regardless of symptoms or neuroimaging findings. So this is why I really wanted to bring up biomarkers in this discussion, because in the next few years, I think our discussion about how we talk about diagnosing dementia is going to look a whole lot different 5 years from now than it does today, maybe even 1 year from now than it does today. So currently, biomarkers are most often tested and detected through things like PET scans or lumbar punctures. And so they're not that often used outside of specialty settings. But there is work to make them available through your blood work. And so in this movement to diagnose Alzheimer's just based on biomarkers, so again, the amyloid and the tau, we anticipate that we're going to see a future in which biomarkers are basically accessible in everyone's primary care office through blood work. And so that is actually how you would diagnose Alzheimer's, not necessarily based on symptoms or imaging, but based on the biomarkers. So I won't dive into that because, as I mentioned, it is dynamic. It is changing as we speak with the presence of these biomarkers serum labs coming our way, coming here, and but more to come. Stay tuned. Okay, so back to how we currently diagnose dementia, and specifically just any dementia, not necessarily Alzheimer's dementia. And this would also be just how you would work up and evaluate cognitive impairment as a whole. So you would first obviously just start with a thorough patient history. And you really want to take a deep dive into those memory, cognitive, and behavioral changes. And if you're going to diagnose dementia, again, this is a progressive, gradual, and onset disease. And so we're going to want to know, when did these symptoms start and how long have they been going on for, and have they progressed or have they stayed the same? So this detailed history about what memory changes someone has seen and about this progression is very important. Along with this cognitive and behavioral history, we'll also want to get an assessment of someone's function and independence. And really here we're talking about the instrumental activities of daily living and the activities of daily living. And we also want to know what someone's function is now. And has it changed? Has this changed over time? Is someone no longer able to handle their finances or no longer able to handle their medications when they used to be able to a year ago or a couple of years ago? We'll put this into the context of someone's medical and social history. And again, we're going to take a deep dive into someone's drug history, including over the counter, because that can, as you'll learn soon, can cause significant memory issues in older adults, our medications. And as much as possible here, we will include informants in this conversation. I do just want to make just a simple communication 101 note here, though, that when someone is presenting to talk about memory issues, or if you're asking someone about memory issues, as much as possible, talk directly to the individual or to the patient and include the informant on the side as an adjunctive and have them chime in as necessary, but really remember that the patient is who you really want to be gathering information from. So there are several validated memory status and assessment tools that capture the presence and progression of memory loss and cognitive impairment. And these tools can be found online, most of them in many different languages, and are really truly made to be used by anyone. And so I highlight a variety of them here, not to say that we're going to go over them all in detail, but mostly just to highlight them to illustrate that honestly, when you're going to choose a tool, what's likely most important is to choose the tool that others around you are using. So what do I mean by that? I mean, what do you people at your institution use? What do your colleagues use, or the subspecialty consultants and the neurologists that you're going to refer to use? What does your preceptor use? And so that is a really important context to know when choosing a cognitive assessment tool, and maybe the most important thing to consider. But it's also good to know that there is a length difference in many of these assessment tools, and there are pros and cons based on some of the different tools as well. So some of these tools here are very brief, taking less than 5 minutes to complete. And so these tools may be most suitable when just screening individuals for cognitive impairment. So someone just comes in, maybe they haven't even necessarily brought it up, or they have, but it's kind of casual, and they're saying, you know, I think I may have some memory concerns, I'm not sure, and you've taken a history and you're not sure either. And so these may be suitable for those situations, but they may be less adequate if you're assessing for really subtle memory impairment concerns or memory impairment disease states, or if you're assessing someone's disease progression over time. So you know someone has mild cognitive impairment or dementia, and you're assessing what's happened over time. These very brief tools may not be the most appropriate in that circumstance. Other tools that are somewhat longer to administer, such as the MOCA or the SLUMS, are more sensitive to detect mild cognitive changes, and therefore are more sensitive to detect mild cognitive impairment. And so if you're trying to diagnose, for example, mild cognitive impairment versus dementia, these can be really great and helpful tools in that circumstance. And they also offer wonderful opportunity for longitudinal assessment over time. But remember that at the end of the day, you do not diagnose dementia just based on someone's performance on these tools alone. It goes in the context of someone's history and their neuroimaging and the rest of their testing. So that leads us to the dementia mimics that I've been alluding to. When you are working up someone's memory issues, you should always rule out other causes that may be mimicking dementia. And there are actually a whole variety of treatable and reversible causes that can cause cognitive impairment that present just like dementia. And the workup for these can be completed in basically any healthcare setting. It's a very, very easy workup, so it's really important to know about these. So here's just a very simple table that I threw together to illustrate just some of the most common causes of these dementia mimics. And I'm not going to go into detail here, obviously, but I just really want to highlight how simple this workup is and how it can be done for basically any patient in basically any setting. But it would include things like, again, depression, low thyroid, low B12, syphilis, HIV, medications is a big one, and then structural brain conditions. So you can see here the workup, we're really just talking about blood work, then doing a thorough med history, and then getting that brain imaging. Now, as mentioned before, this will be addressed in another lecture, so I will not belabor this point, but I do just want to make sure that it is clear that depression is a very important cause of cognitive impairment, and it is reversible. And so it really needs to be a part of your toolkit when you are working up anyone who has memory concerns. Depression can also make memory issues worse in people with dementia. So even after you've already made that dementia diagnosis, you still need to be concerned about depression along the way, because it is something that can contribute to worsening memory issues. And again, it's common, treatable, and reversible. So I won't go into these screening tools here because I think that will be in a upcoming lecture that you have. But my takeaway is similar to the other cognitive assessment tools. It's likely very important to just know what scale is common in your local setting and context. So another takeaway about excluding treatable and reversible causes are just that medications can be so harmful for your thinking. So I won't go through this whole list. I'm just wanting to show this list to you to say, wow, remember to do a thorough medication review. And I hope that you see on this list that some of these are over the counter. Some of these are so common that probably most of our older adult patients are on, and they can cause and lead to cognitive issues. So particularly if you see an association with memory changes at the same time that there's been medication changes, you really need to be thinking about that with medications. And then obviously there are toxins and substances that can also contribute to memory concerns as well. And when you're worried about medications and you're wondering if a medication can be harmful for someone's thinking, don't forget about the Beers criteria. And this is a list put together every year by the American Geriatric Society that's updated and published online that you can reference. And it basically just lists out particular medications that are thought to be very harmful for older adults and are potentially inappropriate to even use in older adults in the first place. So it can be a great place to reference when you're worried about those medications. Okay, so let's say you've gone through that list, those steps of making a dementia diagnosis, and you've made that dementia diagnosis. I won't go into a lot of detail here. It's really outside of the scope of this presentation, but I just want to mention a bit about treatment and just say that although there is no cure for dementia, there is a whole lot to be done after a dementia diagnosis. This is a chronic condition, and healthcare teams as a whole, everyone can play a role, whether that's a primary care clinician, a nurse, behavioral health care member, physical and occupational therapists, social workers, pharmacists, dementia specialists. There's also community resources where you can make community-based referrals for support groups, care services, financial and legal planning. There's also a whole variety of therapies that you can think about that are not necessarily treatments per se, but are really important part of the dementia treatment plan, such as safety. For example, a safety assessment may include helping the patient and family with the logistics of a living situation. So maybe thinking about concerns of nighttime wandering or unwitnessed falls. This also may include an assessment of support, maybe thinking through therapies to help with functional assessment or treating social and emotional behaviors or providing respite care. So you can again really see how all of these different members of the healthcare team are so important here. And then also help with social engagement. So maybe that includes referrals to a variety of different community resources. And then also, you probably know, but there are some prescription medications that are approved specifically for the treatment of Alzheimer's dementia. So cholinesterase inhibitors are approved for mild Alzheimer's dementia. Memantine is approved for moderate to severe dementia. And then amyloid targeted therapies are the hot new medications that you may have heard about and seen on the news. And these are really pretty specialized therapies that only patients that meet very specific criteria can qualify for. So these are only being prescribed basically in centers by neurologists. So the first two medication classes can be prescribed really by anyone in primary care, any clinician. But if patients are interested in looking into some of the newer therapies, they really do need to be referred to a neurologist in a center that prescribes these medications. I'll just end by saying there are a whole lot of free online supplemental resources to learn more about anything I talked about today, including, as I've alluded to, the Alzheimer's Association has a ton of information online. They also provide a lot of information about those risk factors and risk reduction strategies that I briefly alluded to, and other information such as early detection and diagnosis and even caregiver support. The Colorado Department of Public Health and Environment also has a few really helpful websites. I'll just give a brief shout out to their new website, Talk About Dementia, which I've highlighted there, which has some really great resources. They are also working on a Colorado state plan all about Alzheimer's dementia. And they even have a website called Vision where you can see some Colorado specific survey data on cognitive impairment. And I was a part of a team here locally who put together an e-learning module called Alzheimer's disease and related dementias in primary care, addressing risk factors, early diagnosis, and care planning. That is also available for free, and you can get CME credit for it. This is specific to primary care teams, such as primary care clinicians and other team members, and how to potentially address these issues in primary care. Thank you so much for letting me be a part of this series, and I hope that you learned something new, and I can't wait to discuss more at the case series.